My name is Pilar Garrido. I am a medical oncologist at Ramón y Cajal Hospital in Madrid, in Spain. And welcome to our country. And it's my privilege to be here to share with Dr. Rodríguez Abreu the session about the management of patients with EGFR classical mutation as adjuvant therapy or locally advanced disease or even first-line setting. So we have 3 speeches and then a panel discussion with very impressive speakers. So it's time for me to invite Dr. Margarita Majem from Hospital Santa Creu in Sant Pau, Barcelona, who is going to talk about adjuvant therapy. Thank you, Margarita.
My name is MMajem. I'm from Barcelona, and it's my pleasure to stay here today to talk with you about adjuvant treatment in patients with EGFR mutations. These are my disclosures. And also, before I start, I would like to thank the organizing committee for inviting me, and thank you, all of you, to stay here today. Well, talking about resectable disease, we know that it's about 25% of our patients who are diagnosed with resectable disease, and from those, unfortunately, more patients will progress. The most important point is that all those patients have to be evaluated in a multidisciplinary team. We know we have many options, neoadjuvant treatment, so this is very important to be evaluated by all the specialists in the team. And unfortunately, all those patients that goes to surgery, in about 0.5% of patients, they may progress due to the relapse locally or distant disease. And what it means is that those patients, even with a resectable disease, have a very poor prognosis, and some strategies have to be done to improve this survival. What happens with patients with driver mutations? We know that those patients have a different natural history, different initiation of those neoplastic cells, and this prognosis sometimes is lower and have higher rates of metastatic relapse than patients with EGFR wild type. We have the fortune to have targeted therapies in advanced disease. Those treatments have been moved to the early stage, and this has meant an improvement in the overall survival of those patients. In the last year, those drugs have been moved to the early stage with the objective to improve the outcomes, to reduce toxicity, and also while maintaining quality of life. During many years, many trials have been tested with first and second generation TKIs in patients with EGFR mutations. The majority have improved disease-free survival. However, no phase 3 trial have improved overall survival with those drugs. And then I would like to move with a clinical case just to see what happens in our daily practice. This is one patient of my clinics, 78-year-old, that presented with a tumor mass. The MDT decided to go to therapeutic surgery because we do not have the diagnosis, and it was an adenocarcinoma. It was a PT3 PN1 M0 stage 3A with a PD-L1 expression of 80%, but we also performed an NGS that showed an EGFR mutation in exon 21. So, taking into account the ADAURA trial, this patient fits for this trial. He had a confirmed non-squamous cell carcinoma with a common EGFR mutation. We had a brain MRI previously. We have a complete resection, and the fact was to decide if this patient had or not to receive adjuvant chemotherapy that we will talk later. We know that with adjuvant osimertinib for 3 years, there is a significant improvement in terms of disease-free survival for all the patients with stage 2, 3A, and also for stage 1B, with an impressive hazard ratio of 0.23 and 0.27, and also that this benefit is for all the predefined subgroups that you can see in this slide. Also, another important point is that when we analyze chemotherapy according to all the stages that were included in the ADAURA trial, there is a significant benefit irrespective of the stage, with or without adjuvant therapy. So the answer to the question about chemotherapy is not answered with this trial. Again, you can see here in the vast majority of patients that the significant benefit was irrespective of the use of adjuvant chemotherapy. And moving to overall survival, there is also a significant benefit in terms of overall survival in all the population and in the primary endpoint population, and also irrespective of the use of adjuvant chemotherapy. Additionally, there is a significant improvement in the disease-free survival in the CNS metastases, as you can see here. So in this patient, what we decide is to administer chemotherapy with cisplatin and vinorelbine. However, we stopped treatment after 3 cycles due to toxicity. The patient presented fatigue, anorexia, and worsening of the performance status. So we decided to stop chemotherapy. This is something that happens usually in our daily practice, and start adjuvant osimertinib that started 1 year ago. It's well tolerated, no severe toxicity, and the patient is still receiving treatment with osimertinib with no evidence of disease recurrence. Another important point to keep in mind is that we are administering a long treatment to a patient that is cured. Sometimes it's difficult to follow these treatments in the adjuvant setting. We have many evidence from other trials and other tumors like melanoma, in which we know that adjuvant treatments are not as well tolerated and in advanced disease. So what is important to keep in mind is that those treatments do not have to affect the quality of life of our patients, and what we see with the ADAURA trial is that the quality of life was maintained with the osimertinib during the adjuvant treatment. And also, it's important that the safety patterns are not as too high to affect these daily patients. So, I have another case, because there is another important situation that we will have in the future. This was a young woman, never smoking, that appears with a suspicious lesion, and she underwent surgery. And we found an adenocarcinoma PT1N0, stage 2B, with an exon 18 mutation. She received adjuvant treatment, and then she was included in the ADAURA trial. She received osimertinib placebo for 3 years with a low toxicity with grade 2 rash and diarrhea. And she stopped treatment, and several times later, she presented with a locoregional relapse that was diagnosed with mediastinoscopy. It was an adenocarcinoma. We detected the presence of exon 19 mutation. We broke the blind, and we knew that she had received osimertinib. This is something that will happen probably in the future. We also know from the ADAURA trial the majority of patients had a locoregional relapse. That is what we saw in my patient. So what we did in this case was to administer concurrent chemotherapy and then restart osimertinib with good tolerability, and she's still ongoing with the treatment and in complete response. So from this trial, from the ADAURA trial, we have several questions, and I think that the most important one is the first one. Is adjuvant chemotherapy still needed in those patients? We do not have the answer. The easy answer is to say that in the trial, all patients with or without adjuvant chemotherapy benefit from this strategy, and probably it's more a physician decision that has to be shared with the patient. But we have to know that there are a pool of patients that will be cured with adjuvant chemo, so it's important to keep this in mind. Maybe strategies like minimal residual disease can be helpful to decide which patients may need a more intensive adjuvant treatment, but this is something that we have not too many patients from the ADAURA trial to know what happened with those patients with minimal residual disease, but those patients get better with osimertinib. And there are also strategies ongoing to try to avoid adjuvant chemotherapy in those patients who are negative MRD. Another point to keep in mind is that in the first line, we know that the combination of osimertinib plus chemotherapy seems better to osimertinib alone in terms of progression-free survival. So maybe an option is to start osimertinib together with chemotherapy to avoid this early relapse in those patients that may delay the use of osimertinib after adjuvant chemotherapy. We also know with longer follow-up that there is a small increase in the hazard ratio, and there is a suggestion that maybe longer treatment with osimertinib may be better. This is something that we have seen in patients with breast or with GIST cancer. And there is the target phase 2 trial ongoing that will test the role of osimertinib for 5 years. Another point is that if we can offer osimertinib after incomplete resection, we know that patients with the ADAURA trial were patients with completely resected disease. But we also know from the LAURA trial that those patients with unresectable disease benefit from adjuvant disease. So probably the answer is yes. In those patients that have unresectable disease, we have the possibility to do an adjuvant treatment and then to give osimertinib. And we also know that this toxicity profile is not so bad, so there is the option. And another point that I also think that it's interesting to consider is that those patients that you can see here, stage 3B, are patients that we can find in our clinics after surgery, and those patients were not included in the trial, but I also believe that those patients will benefit from adjuvant osimertinib. So to conclude, the scenario of early-stage disease in non-small cell lung cancer is rapidly evolving. Osimertinib is part of the standard of care in resected patients, and to date, the need of adjuvant chemotherapy is unanswered with ADAURA trial. Early stages have entered in the era of precision medicine. EGFR, PD-L1 and ALK testing are part of the routine assessment in adjuvant setting, and the future challenge will be how to incorporate other targeted alterations in the routine, especially in the neoadjuvant setting. And to finish, the use of surrogate endpoints may be helpful in early stage for the escalation strategies. Thank you for your attention.